Welcome to the Onco PT podcast, where you'll learn from oncology experts, practitioners, and patients to help you on your journey to become a confident and competent Onco PT. Here's your host, Elise Cantu.
Hey, Onco PT, and welcome back to this episode of the Onco PT podcast. Now, if you listened to last week's episode, you already know how amazing the Cancer Rehab Community Conference 2024 was. It's now 3 weeks after the conference, and I still cannot get over the high. And to keep the excitement going, because I'm not ready to let go of such an amazing experience, I want to keep talking about it. But I'm not going to make you sit through another episode of me talking about how amazing the conference is. I'm going to give you a little sneak peek on what actually happened in the conference by letting the speakers themselves talk to you and get a little snippet of what they actually talked about at the conference. Whether you were there or not, you still get to have a little bit of the conference magic. And I hope this also inspires you to sign up for next year's conference, but we'll cover those details at the end of the episode. So let's go ahead and dive right into our first clip. Now, this first clip was actually our first speaker, Dr. Katie Schmidt, whose presentation was all about CSM, specifically this manual therapy protocol that she is pioneering to help her patients with CIPN, both in the hands, but especially in the feet, which is what she really focused on in our conversation at our past conference. And I really love, in this clip, she's talking about how she discusses and describes CIPN with her patients, because let's face it, we've heard neuropathy before. Many patients may have, experienced it previously. They're experiencing it now. They've heard of somebody who has neuropathy. But who really understands what neuropathy is? And if you're watching this, you know that my hand is raised too. Because while I get that chemotherapy and other agents actually affect the nerves, the peripheral nerves in this sense, I didn't really understand for a long, long time how they were affected, what this actually did to those nerve endings, until I actually sat with Katie at a previous podcast recording that we did back in 2024. And after hearing Katie's presentation and these analogies on how she talks about CIPN with her patients, I will definitely be stealing these and using them with my own patients in my own practice who also have CIPN. Take a listen.
To not bore my patients with a bunch of jargon, I like to kind of describe it as a leaky battery and then a bad phone wire. So for the muscle issues, it's kind of like you're a flashlight with a battery that's sort of leaky and doesn't fire correctly. The muscle twitches, it doesn't know how to control itself. With the phone wire, it's like you're a copper wire wrapped in plastic, and the plastic has been messed up, and so it's sending a signal and it doesn't really know what the message is, but it usually comes out as tingling or burning or numbness or something like that. So it makes it a little bit easier to explain to your patients.
As an early career onco PT, I learned quickly that certain cancer treatments are cardiotoxic, are toxic to our lungs, but I didn't really know what to do beyond that. It was more of a appreciate that this is happening and then just kind of document that somewhere and then move on with the rest of your stuff. Now, fast forward to today, I have a little better understanding, but what has really changed the game for me is this presentation, this next clip, by Dr. Julie Skurzat, who is a cardiopulmonary whiz in physical therapy. And what I love about this clip in particular, during her presentation, she talked about, how do certain cancer treatments cause cardiopulmonary issues? How do these manifest for our patients? But she didn't just stop there. She also talked about, what do we actually know? What is in the evidence that we can harness to leverage in order to help our patients who have very significant cardiopulmonary issues, including heart failure? Now, in this clip, Julie acknowledges that these guidelines she goes over are for the population with heart failure, not specific to oncology. But I believe that there is a lot of crossover between what Julie goes over in these guidelines and what we can then take and apply to our own patients. Take a listen.
And I wanted to give a shout out to the CPG on management of patients with heart failure that was published in Physical Therapy in 2020. What the recommendations say is that in patients with heart failure, now this is without cancer, so that is a caveat, but in patients with heart failure, we should be challenging their systems. This includes aerobic exercise at, you can see, a very high intensity of 50 to 90% of peak VO2, Also, high intensity interval training has strong evidence and recommendation, and resistance training at 60 to 80% of their 1 rep max. So again, I say this so that we don't necessarily shy away from these patients and think that they're fragile. Of course, they may be medically fragile, and we need to be more sensitive and attuned to signs and symptoms, but we should be challenging them.
By now, you probably have a very good understanding of when a person comes to you with a particular cancer diagnosis, with a particular set of impairments, that there are certain objective measures or outcome measures that, are tested to be really valid and reliable in this patient population. And you should incorporate those into your evaluation. Awesome. We're all for that here at the OncoPT. But the reality of actually making that happen in day-to-day practice can be really challenging. And it's easy to get kind of down on yourself and say, I understand it. I get this is important. I don't know how to actually make this happen with my own patients in the own set of circumstances that I work under. And friend, I totally get you, because that is exactly where I'm at. And that's why I loved in Dr. Andrew Tongaway's presentation. He was real with us. He got on our level as someone who works day in and day out with oncology patients, and was basically like, hey, we know this is really important. Here's how I actually double dip on things to make all of this work with my patients. Or here's how I prioritize some of the test and measures and the objective, outcome measures that I will use with my patients to gather all of this information. And again, while you never need permission from any of us here at the OncoP to go and do stuff in your practice, I do have to admit, hearing Andrew kind of give permission in a sense on, hey, you got to do what you got to do. Here's how to make this work in your practice. It was such a freeing feeling. And I know you're going to feel the same way once you listen to this clip.
For me, really what I focus on is I look at, assessing cardiorespiratory endurance and lower body and upper body strength. So for me, again, it depends on what setting I'm in. If I'm in the hospital, I might use that 2-minute step test. For our RTM pilot study, I have to use an RTM step test because a lot of my patients are telehealth. I can't have them necessarily, a lot of my patients don't have the space to walk around 6 minutes. I can't necessarily trust them to set up a course for a 6-minute or 2-minute walk test that way. And obviously I need to be there if I'm going to have them do a treadmill test. So there's a lot of different variations that we can use and see, and it does help us to assess. The 2-minute step test is great at assessing as a patient have good balance even too, because they have to be able to weight shift. They have to be able to get on that one limb, and seeing how strong their actual hip flexors are, because a lot of patients for me in the beginning, they tap out because their hip flexors are starting to tighten up on them. For me, for strength, 5 times sit to stand, 30 seconds sit to stand is one that I do all the time as well too. It's very straightforward. It's fast. You can actually capture both of them in the same thing. I was like, all right, up and down for me for 30 seconds. I count how long it takes them to do the first 5, and I count how many overall reps they get. And even if I'm doing those 2 tests still, I will still test with, machines, dumbbells, kettlebells, and some body weight exercises. Might not all be on the first day. There's a lot to get through, but it's still, I'm trying to capture these so that I have my data points and my starting values for really building this program for them as well too.
OMG, y'all. You've heard me talk about this before. I still can't believe that we got Dr. Susan Maltser to keynote day 1 of the Cancer Rehab Community Conference. And boy, did she deliver. Now, her presentation was all about safety considerations in cancer rehab, which is my jam. Just absolutely hands down, to date, my favorite article in all of Cancer Rehab, and one of the most important ones, I would say, is A Focused Review of Safety Considerations in Cancer Rehab by Maltser et al., 2017. A classic, y'all. And what I really loved about this presentation by Dr. Maltser is it not only went over, what are some of those guidelines that came out that we, have known, we have gotten to know and love over the years from that initial, landmark article, but also one of the topics that she covered multiple times in this presentation was all about common sense precautions. Mind blowing phrase. Simple enough, right? These are not these are not crazy words that we're learning for the first time, but just that string of words together made so many things click for me. And from what we saw in the chat, a lot of the other attendees at this conference on, okay, we know that there are, of course, certain safety principles that we need to adhere to when we're working with this very dynamic patient population. But a lot of what we know is informed and guided by fear rather than actual evidence. And I love in this clip that Dr. Maltser not only acknowledges that background behind many of the, especially like the modality contraindications that we know, but also how to actually take this with a grain of salt or maybe a whole bucket of salt, depending on what we're talking about, and kind of consider the whole picture of the patient and what that patient really needs and what kind of risk benefit ratio we're really working with when you're choosing to or to not implement different treatment techniques with your patients. And again, I think I love to hate on ultrasound because I thought it was so silly to learn about in PT school. And now I have not used it once in my entire clinical practice since I have been a professional PT because I've never had one wherever I've worked. But I love that Dr. Maltser, again, takes these, what she calls common sense precautions, and really says, okay, here's how we can actually do this in your clinic. Here's how this, should ultimately play out with your patients, why we have these, kind of old, outdated guidelines, and how we should really be practicing with our patients ultimately for their highest benefit. Y'all, obsessed, simply obsessed.
The thinking used to be like cancer ultrasound in a cancer patient, period. Nowhere it can cause the spread of cancer, right? So one issue with modalities compared to the other topics I described is we're simply not going to have studies and definitely not randomized controlled trials looking at this. Like no one's going to say, let me put a hot burning deep probe over your tumor and see what happens. So basically we have to just use like some common sense. And what I would say common sense with ultrasound is don't apply over a direct tumor site. Don't apply over, skin that's been irradiated. Don't apply over insensate areas where, a patient may not have good skin quality. But I think if, a patient has breast cancer, but they have a shoulder tendonitis, and we're thinking that an ultrasound may help with the tendonitis in order for her to do radiation, I think that's a risk-benefit ratio that I'm going to accept. In addition, there's a lot of interesting studies coming from our radiation oncology colleagues where they're using these deep heat to treat bone metastasis. And so they are coming up with all kinds of treatments, right, that are, invasive right to the bone to treat metastatic disease. So we don't have those studies yet. So I don't want to cite them. Again, I just want to have like common sense precautions.
One of the biggest complaints that I frequently hear about in OncoPT within cancer rehab is, I'm doing really good work. My patients love me because, of course, your patients love you. You're doing great work with them. You're helping them achieve their goals, work towards whatever they're trying to work towards after they've been diagnosed with cancer. But I'm like the best kept secret in my town. Nobody knows about me, or nobody's referring to me. How in the world am I supposed to get more patients? Well, Dr. Abby Hegerfeld is literally helping cancer rehab professionals across the country answer this question and then also fix this problem in their own communities. And so I was so thrilled that she presented at the Cancer Rehab Community Conference specifically on this. And buckle up, friend, because what she talks about, I find that a lot of PTs are kind of like, they shirk back or they kind of cringe about it. And friend, there is no reason to. In fact, you absolutely should be doing what Abby talks about. And if you're not, you are literally taking yourself out of the conversations, out of the rooms, out of the spaces where these decisions are being made. Friend, you need to be at the door, right? At the room, in the clinic, and the wherever, helping to make this happen. And the only way you're going to do this is by implementing what Dr. Abby Hegerfeld talks about in this next clip.
How can we collaborate? Ultimately, you need to market yourself. You need to help these doctors and help these institutions understand how you yourself or your clinic, your department, how are you guys going to be better suited to treat these patients than another clinic? Ultimately, someone told me once that you have to prove that your programs are going to benefit the patient's treatment plan and not just add more to it. So these patients are, sometimes have multiple appointments in one day, appointments every day of the week. The last thing they want to do is come to physical therapy 2 or 3 times a week. One of the first things that we often tell our patients when they come to see us is we are not your traditional physical therapy. Our goals change throughout the course of your treatment, but ultimately we want to help make sure that your treatment is staying on track. And we want to make sure there's no delays, there's no gaps, and that, you're staying as healthy and feeling as well as you possibly can throughout the course of your treatment.
Now, unless you see a lot of patients experiencing head and neck lymphedema, or this is of a special interest to you, you probably don't spend a lot of time thinking about or working with this very special patient population. And for many of us, when we go and do our CLT training, so Certified Lymphedema Therapist training, we learn how to manage upper extremity and lower extremity lymphedema, but don't always get around to the head and neck. All this to say, unless you really take the time and the effort to learn this by yourself, you probably don't learn a whole lot about this. Learn what to do for patients who have head and neck lymphedema. So in our speaker, Manisha Agarwal's presentation, she talked all about, what is head and neck lymphedema? How does it affect a person? What do we do about it? She interwove at every step of the way different patient cases that she was working with, either currently or previously, with lots of really rad pictures too, which I totally loved. And in one particular patient example that she gave, she talked about how Manisha came in to this patient session and was like, okay, here's the plan. Here's what we're going to do. I know exactly how to fix this. This is the plan. We got this. We just got to implement the plan. And the patient pushed back and said, that is not going to work with me and my life. You need to come up with a different plan. And y'all, if sometimes we don't need a good swift kick in the pants like this to kind of get us back to reality and realize that this is not just the Elise show or, insert your name here. This is the patient and Elise show. Again, patient and you show. And we really need to be more cognizant of, while we may have the best intentioned, well-laid plan, that may not actually work for our patients. And so in this clip from Manisha's presentation, she really goes into, I would love to implement XYZ with my patient, have them do all these things. But I know that if we're going to work together as a team and have the best outcomes in the long term, where there's buy-in from the both of us, I have to manage those expectations. I have to kind of, check my ego and really make sure that I'm approaching this alongside the patient to make this work. And I really, really appreciate that perspective.
As I was saying in the few slides before, that exercise helps to move the lymphangions better. It helps in the contractility of lymphangions. So it's not just for physical and emotional well-being, it helps also with the optimal functioning of the lymphatic system. And it is something that the patients can do on their own. It is so, in terms of home exercise program, I'm just going to mention a couple things about that. I try not to give a lot to the patients. There is a lot. There is MLD, there is scar work, there's compression garments. And then they have to think about their posture. They have to think about what to eat. They have dry mouth. So there is a lot. So I tell my patients, you are not going to do everything that I am doing during the session. I will give you just 2 or 3 things to do. And that's all I want you to do. They're like, that's all I have to do. And I say, yes. And that is plenty, because using the basics of the lymphatic system, what moves the lymphatic system? Movement. And that helps the patients a lot. So I give them a couple exercises, and then maybe show them a very simple way of self-massage or scar work if they ask me. But again, I focus on simple things, very few things, so that they don't feel overwhelmed and they come back. Otherwise, it is really hard to get the buy-in, because the impairments are very severe and they are present for a very long time.
Now, our last speaker of day 1 is Hannah Stetler, who is an occupational therapist and is actually a breast cancer survivor herself. And perhaps most special of all to me was actually one of my patients several years ago, shortly after she had finished cancer treatment. She talks a little bit about how we got connected, but I so love Hannah's perspective. And, as much as we know we're doing really good work, I know that you're listening to this because you always want to be doing better for your patients. You're constantly seeking ways of, how can I be a better therapist? Hannah's perspective as a patient, as a cancer survivor, and now as a professional herself, as an occupational therapist, the perspectives that she has and the commentary from her own experience on all of this was the perfect way to end day 1 of the Cancer Rehab Community Conference. I don't have a whole lot more to say about the clip, except for I'm going to stop talking and let Hannah do the talking, because you need to listen to her words, y'all. Pure gold.
When I was going through treatment for cancer, I was 100% in fight mode the entire time. I did not let myself feel all of the feelings that I was feeling that were really there. I did not let myself think about the what ifs. What if this doesn't work? What if I don't make it? How is my daughter going to survive without a mom? And the truth is that all of those feelings were there. I just hid them really, really deep down. So once treatment ended and my sweet surgeon called me to tell me that there was no evidence of disease, that's when all of the feelings started rushing in and I was hit like a truck. And within this week alone, friends that I had made who were going through very similar journeys were not as lucky, and it was really, really tough. So I began to work out daily because a doctor of mine once told me a workout a day keeps the cancer away. And it was then that I started to deal with frozen shoulder. And I remember in my head at that moment, I had just finished treatment. My arm was hurting. I couldn't move it. And I immediately went to worst case scenario. Oh my goodness, cancer's back and I'm dying. And that's literally where my mind went, which probably is the mind of a lot of your patients too. Luckily, my oncologist referred me to see our very own Elise. And she was an angel on earth. And she helped me more than I could ever explain. And every week I would go see her. And of course, she would help me with the physical challenges that I was dealing with, the mobility issues, the pain, the stiffness. But she also helped me with the psychological challenges as well. So she listened to me and she offered support and she offered solutions. And I cried with her multiple times, more than I would like to say. And I think she shed a few tears too. And I say this to you to explain that our calling as therapists is not just to treat the problem, but to treat the entire person, mind, body, and soul. And it could be as simple as giving them options for bras after surgery or resources for counselors to talk to. It could be as simple as a hug or a shoulder to cry on. It could be as simple as giving them validation. Like, yes, what you went through was hard. And yes, what you went through absolutely sucked, but you did it. Again, mind, body, soul, we care for the entire person. And that's what makes us as therapists so unique in this entire process.
As powerfully as Hannah closed day one of the Cancer Rehab Community Conference 2024, Dr. Lori Bowright opened day two with just as much power and gusto. So her session was all about considerations for rehab when it comes to the palliative care domain. So working with patients, again, not just in a hospice setting where it's end of life care, but also in stages, where a person may have more advanced cancer, but also really operating within the full scope of what it means to be in palliative care, from the point of diagnosis all the way through treatment to whatever that endpoint is for that patient. And oh my God, y'all, so good. Nuggets of wisdom throughout this entire presentation, but this one clip in particular really stood out as not only like, yes, man, we do good work, but also really built on. And I loved it so much. A lot of the speakers did a really good job of like building off of others' topics. That happened the whole 2 days. But this in particular, this clip from Lori, I think is going to give you a lot of callbacks to Dr. Abby Hegerfeld's presentation on day one, which was all about you've got to sell yourself. If we're really going to advance collaboration in OncoPT and cancer rehab, we have to do this. And Lori's presentation, particularly this one quote that she's going to go over, I think just took that and kind of blew my mind up to a new level of like the urgency behind this and how imperative it is that we got to do this now.
I'd like to just pause briefly and provide a wonderfully insightful quote from our APT Oncology president and accomplished palliative care researcher, Dr. Chris Wilson. He has this to say about palliative rehabilitation. So rehabilitation professionals have an extremely unique and valuable set of skills to improve the quality of life of patients and contain healthcare costs in palliative care, but only if we are at the table. We have to invite ourselves to the table. We cannot wait for an invitation. These patients need us right now. So, very poignant words. Those who know me know that I do talk very fast. I was intentional about being slow and purposeful with those statements. A lot of what is happening in our profession is coming from this approach. We are realizing the benefits of our profession in all domains, but specifically related to oncology rehab and also the palliative care domain. We can't wait for people to recognize what we do. We have to promote what we are doing and we have to put it forward. So that quote really, I would clip it and put it on your near your desk as a constant reminder that we are capable and we do wonderful work, and it needs to be recognized in all domains of healthcare.
In OncoPT, we talk a lot about, forming a therapeutic alliance with your patient. I feel like I first heard about this kind of like topic or phrase in PT school, and it continues to this day. But I think I'm kind of changing a little bit on how I approach this and how I frame this in my mind, especially after this session at the Cancer Rehab Community Conference. So day two, right after Lori, we had Dr. Adam Matichek, who presented on trauma-informed care. And not just a, here's what it is, but also how can we bring this and integrate this into our care intentionally with our patients, and really acknowledging the trauma that many of our patients, if not maybe all of our patients, have experienced at one point or another. Now, Adam goes on to talk about, he is a tall dude. Now, I've actually never met him in person. I cannot wait to do so at CSM coming up in February, because there's going to be a significant height difference between us. But Adam talks about how he, as a tall male therapist, is really working to take the steps within his own practice to make a more healing, trauma-informed environment for his patients. Now, while you may be listening, like me, and saying, well, Adam, that's good, but I'm a 5'1", I'm looking at myself in the screen right now. I'm a 5'1", not very tall female therapist. Like, I'm probably already doing a good job of this. Friend, I'm going to push back. Because what Adam talks about and what he continued to go into in his presentation really highlighted a lot of areas for me where I know that I need to be doing more intentional work every single day. So not just like big one-time changes, every day. How can we show up and be better therapists, showing up for the human in our patients as the human us? Now, Adam says it much better, so I'm going to turn it over to him, okay?
When I talk about creating a safe environment for our patients, we need to create an environment that emotionally is inviting for them to want to share these experiences with us. So we want to make it safe. We want to make it welcoming, non-threatening. In the acute care setting, I'm a big guy. I'm 6 feet tall. I'm 260 pounds. I was a linebacker. When I walk into a patient's room, I take up the doorway. If I stand at the end of their bed and cast them in shadow and start firing questions at them, that's going to make them feel, very small, very, they're going to be more guarded. But if I can walk into that room and I can pull up a chair and sit down next to their bed, if I can get down on a knee, it's the nice thing about wearing scrubs to work. I don't have to worry about what I'm kneeling in. Kind of getting down on that level with your patient, having that face-to-face, eye-to-eye interaction with them. And then in the outpatient setting, right, making sure that those clinic rooms are inviting, that it doesn't feel like kind of that sterile doctor's office feel. And then considering environmental triggers for patients, the noise level, the amount of privacy that they have. And that goes both ways. If they want to have these conversations one-on-one, finding that space or finding, that area in the clinic, making sure that when you're in that patient's room, the curtain's pulled or the door is closed, so you can have these conversations.
Our next speaker, Dr. Tori Crook, has a really unique experience and perspective when it comes to OncoPT. She originally started her career in outpatient oncology PT and has since transitioned to inpatient acute care oncology PT. And watching this all happen, first of all, has been very cool as her very local colleague here in Fort Worth, Texas. But what I really appreciate is that Tori didn't just dive into acute care oncology and say, all right, let's make this work. She takes principles and perspectives and experiences from her outpatient days. But what she's also doing that's really working to transform acute care oncology PT at her institution is also understanding the role that acute care plays kind of within the context of a lot of different spheres. In her presentation, she also calls back to Dr. Rebecca Griffith, who we've had on the podcast multiple times, who you may know as the ED DPT, the emergency department physical therapist, on how the emergency room, as Rebecca puts it, is the new primary care for many Americans. And Tori poses the question in her presentation, if the emergency department is the new primary care, what does that make acute care? And what does that mean for oncology physical therapy within acute care? And kind of really taking what's been very traditional and well established in acute care oncology PT and kind of turning it on its head. And I have to say, I am here for the rides, my friend, and I know you're going to love it too.
Traditional acute care therapy and their problems in the oncology setting. So typically when you think acute care, we're thinking a short-term admission. In our oncology patients, we have some that are getting admitted and they are planned to stay at least 28 days. This is usually for chemotherapy. And 28 days, usually they end up staying a lot longer. So that traditional approach, if they're only going to be here for a bit and they're out, does not apply. We also kind of have the mindset of okay, we're going to address the impairments related to the admission diagnosis. Problem with our oncology patients is whatever impairments they have are most likely about to get worse, either as a result of the treatment or just the disease progression itself. And then another thing we typically see, especially with rehab services, is we're going to discharge therapy once the patient is independent with gait and transfers. So they can get out of bed on their own, they can walk down the hallway with supervision, we're out. Problem with that for oncology patients is their functional ability is going to fluctuate depending on their treatment and, again, that disease progression. Another common mindset is once we see patients are transitioning more to like a hospice service, we discharge therapy. And then shortest way to say this, the problem with that is that they're not dead yet. And we will touch on that a lot more later, kind of at the end.
I could have listened to this next speaker present for the entire conference and would have been as happy as a clam. And I'm not even joking, y'all. Dr. Yoshi Schonborn presented on demystifying basically the problems in the chest, the axilla, and the arm shoulder area that many of our patients with breast cancer experience. So what are some of the problems that patients experience as a result or, post breast cancer and breast cancer treatment? And then, of course, as we like to do at the Cancer Rehab community, what the heck do we do about it? In this clip, Yoshi goes into a little bit of differential diagnosis because I'm sure you've experienced sometimes our patients don't come in with a nice, clean, defined, distinct list of issues. Sometimes they have a bunch of issues that are all related to each other, and we have to tease out what the heck is going on, what the heck to do with it. And Yoshi really goes into, here's a way you can start doing that. Here's some things to consider when you're working with patients. And so the specific examples talked about would be axillary web syndrome and then also some like neuro issues as well, which I'm going to be completely honest, before this presentation that Yoshi gave, I didn't even think about those two things being an issue at the same time in this capacity. And I'm really, really glad that they did go into this. And this is definitely, if you purchase a ticket to the 2024 conference, you have access to the recordings until next year. I would encourage you, go back and listen to this session again and again, because I've now listened to the session 3 times. And I'm going to do it again, at least, because every time that I listen, I get more and more out of that session. And then it sinks deeper into how can I actually implement this with my own patients in my own practice.
The other thing I want to identify from that last slide, I apologize I didn't mention yet, I'm picky, as you might have noticed, about these things. I think precision can be really, really helpful for getting good and consistent outcomes. I think neural tissue is sometimes implicated in axillary web syndrome, and I think that nerve glides can be very helpful for it, but I'm not sure it's always because it truly is neural tissue. A thing that's linear, starts at the axilla, goes down to the elbow, and ends at the thumb does sound a lot like nerve. But what I'd say is that if what you're noticing is that when the patient extends their elbow and elevates the arm, and they get symptoms that radiate distally. But if they bend the elbow, they don't have symptoms. That's much more consistent with potentially either of those two things. It could be cording or it could be neural tissue. But if the patient has a straight elbow, elevates the arm, and then ipsilaterally side bends the neck, now they're slackening neural tissue. And if that doesn't have an impact, that's much more characteristic for me of being cording versus if slackening that neural tissue reduces the load to the tissue and reduces tissue irritability as a result, that makes me much more suspicious that maybe the nerve glides are actually the main thing we need to do, not necessarily the lymphatic drainage as much, or not necessarily some of the myofascial techniques that you often hear discussed for treating cording. So I know it's a fire hose. The great news is that this is recorded. So I figure that some of these things may be worth touching on in the future or as you sort of see patients later on. But again, thinking about that broader sense of how specific can we get so that we can see a change within session so we can prove to a patient that they actually can get better, because so many of these people really and truly can get better.
Oh my God, last session, y'all, we made it. You heard me talk about previously how excited we were that Dr. Susan Maltser was our keynote speaker for day 1. And boy, oh boy, our day 2 keynote speaker stepped up and delivered also. And that would be the Dr. Nicole Stout. I know. I still can't believe it. Now, Dr. Nicole Stout talked about, frankly, a lot of things in her keynote presentation. But in this particular clip, we're highlighting some of the research that she and her team at WVU, so West Virginia University within the oncology department, are really working on and looking at. And now I will be completely honest. When she first started talking about this research, I had some preconceptions about West Virginia. I was like, it's very rural. That makes sense. I imagine there's not a lot of available cancer rehab resources for these patients. And that's correct. That would be an accurate statement. West Virginia is very rural. But that actually did not answer completely why so many patients don't have access to the support and the services that they need from a cancer rehab perspective. So just to give you a little context on kind of what we're talking about here, Dr. Stout does go into what those factors were and ultimately what this means for us. But I found it really interesting because, again, even though you probably know West Virginia, very rural, kind of makes sense from a surface level why patients may not have the best access. But then it also got me thinking a lot about what happens here so I'm in Texas, and there's parts of Texas that are quite rural. There's also parts of Texas that are quite urban, quite metropolitan. And even with Texas is a bigger state, we have a lot more people. I saw a lot of parallels between what Nicole was talking about happening in West Virginia and also what I see here in Texas. And I bet that a lot of what is discussed in this next clip is probably also happening in your state, in your area, with your patients. And I would love to know your thoughts on that. So be sure, if you would, listen to this next clip and then message me on Instagram to let me know your thoughts, because I would really love to know them.
And we said, we live in a pretty rural state. And so we looked at rurality, which are the light green areas. So patients who lived with high needs, were they in more of our rural areas? So was it the access to care because they lived far away? The blue areas are the non-rural, technically non-rural areas of West Virginia. And we found that there was not a correlation. Next slide. And then we mapped to social deprivation. Social deprivation is a way of looking at the socioeconomic characteristics within a county or a zip code. So socioeconomic factors, poverty levels, education levels, housing density, healthcare access, food insecurity, all of those come together to create these models for social deprivation or social vulnerability. And what we found was that our individual patients who had the highest levels of unmet needs correlated positively, actually the association was very high, with the areas of the state where there were the highest levels of social deprivation. So the disparity is the driver, right? And so we've taken that really to heart, and we've said, how do we meet the needs of patients in these very socially deprived, socially vulnerable areas? Next slide. So what we decided to do then was look at what is our resource capability to bring better services to these patients. And we mapped all of our primary care facilities throughout the state to look at where do we have primary care facilities that could be an opportunity to provide services. We asked, where are our mental and behavioral health clinics that could be an opportunity to provide these services? We said, where are our rehabilitation and exercise facilities that could be available to provide these services? This was shocking to me to see the rehabilitation and exercise facilities with this frequency of occurrence across our state. The little black stars are the only ones that have cancer-specific rehabilitation programs, right? So not quite ubiquitous, but boy, we've got a lot of potential opportunity in where our exercise, fitness, and our rehabilitation services lie around the state. But all of these services, in our environmental scan, I had a group of students who collected this data, mapped it, called a sample of services from primary care, mental health, rehabilitation, exercise clinics. Guess what? The majority of them were like, oh, cancer. Yeah, we don't do that here. That's usually handled at the Cancer Center, at WVU, the Cancer Center at Charleston Area Medical Center, the Cancer Center in Huntington. That's not us, right? So tremendous opportunity to manage cancer-related morbidity. Tremendous capacity exists. but we don't have the knowledge and skills in the workforce out in these community centers to help to support our patients with cancer. So we need a paradigm shift, right? Getting this done in our cancer institutes is only half of the battle here, because people are going to go back to the communities that they live in and work in with their families and their trusted neighbors and their trusted providers. How do we reach those areas?
With that, it is finally time that we wrap up this year's Cancer Rehab Community Conference 2024. It was an amazing experience. I am already looking forward to next year's conference, although I'm so bummed that this year's conference is done. I don't know how we're possibly going to top it. We are. Let's be clear. I know we are, because I know that the speakers who are going to present at next year's conference are going to meet and exceed expectations just like this year's speakers did. But man, there's something to be said for working on something for an entire year, and then it happens and it's even better than you planned for. And I'm just so grateful. So first of all, thank you so much to all of our speakers that made this such an amazing conference. You are the champions, my friend. Like, you made this happen. Thank you so much to all of the attendees who put your faith in us for delivering yet another amazing year of the Cancer Rehab Community Conference. Cannot wait to see you at next year's conference. You can find the link. We are already selling tickets for next year. I know early bird pricing is now available. You can find those at the oncopt.com/conference. I cannot wait to see you there. And I do have to pause and thank my amazing co-founder of the Cancer Rehab Community, Dr. Kelly Sturm. You know her as Cancer Rehab PT. Amazing. I absolutely would not have been able to pull off this conference again this year without her working furiously behind the scenes, all the way up until the conference, through the conference, and after the conference to make this happen. So thank you so much, Kelly. I so appreciate you. And I appreciate you, listener, for taking this time to spend it with me and all of the amazing speakers from the Cancer Rehab Community Conference 2024. Again, save your seat today for a discount. That's right. Early bird pricing is discounted. You can find your ticket at the oncopt.com/conference. And I cannot wait to see you there at the Cancer Rehab Community Conference 2025. But until then, this is Elise with the OncoPT. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.
Thank you so much for listening to this episode of the OncoPT podcast. If you'd like to help support the podcast, please share it with others, leave a rating and review, or support us on Patreon.